Oh, definitely. So in Dr. Nakamura's session, which came after mine, he goes through the role of transplantation, which is adoptive cell therapy that we have really been relying on. So there are many new targets that we're looking forward to seeing more mature data, where the prelim data so far looks super encouraging. Some of those include looking at novel checkpoint inhibitors, including TIM3 receptor antibodies, CD47 or SIRP alpha inhibitors, and also looking at maybe small molecule inhibitors such as IRAK4, FLT3 combined inhibitors. I also presented some data from the DART therapies with CD3, CD123, and the CD123 conjugated protein 2 diphtheria toxin. So there's a lot of novel ways that we can now target the immune system. We still have been relying on the immune system heavily for long remissions for our patients that undergo transplantation. But in terms of therapy, it remains uncharted waters. There's a lot more maturation of data that needs to happen. So we're waiting for a lot of phase 3s to come forward with their more mature data. But in the meantime, there has been really encouraging preliminary data suggesting that we may get another immunotherapy of interest in the near future. Yeah, it's been really hard for us to essentially follow what other disease subsets do in MDS. So in ALL, for instance, my colleagues presented how they're starting to find data that might suggest maybe you don't need to go to transplantation, and that's not the case in MDS. We still really rely heavily on it. And in solid tumors, we've been blessed with data that shows that chemo-resistant patients or patients that don't respond to chemotherapy there's a subset that can really enjoy cure with traditional checkpoint inhibitors like PD-1s, PD-L1s, and CTLA-4 blockade. However, in the MDS setting, that really hasn't translated as much as we would like. And so what's been happening over the last decade is more creativity into looking at other novel targets, maybe in the innate immune system, or looking at small molecule inhibitors that might leverage the immune system as well, and that has been really encouraging for us. So I think the challenges are adopting what our other colleagues have been doing in other disease subsets. MDS is really a unique type of disease, and so we've been more creative, I think, in the last decade in trying to figure out novel ways to use the immune system in new immune targets. Yeah, that's a really great question. So MDS is a heterogeneous disease, and so many of our patients have multiple mutations and rely heavily on multiple driver clones, and so it's been really hard for us to have just one type of drug there's no one size fit all. And it's been really difficult outside of disease subsets like IDH1, IDH2, which has a great small molecule inhibitor available for that specific subset. We really haven't been able to do that with the majority of the MDS patients, like over 90%. They tend to have multiple mutations and difficult to target. So what we've been doing with a lot of therapies is, once we introduce it into the relapse refractory setting or frontline, we study the baseline and on treatment NGS patterns to try to understand if there's sensitivity or resistance. And we're starting to look at things like immune signatures as well. So we're really leaning on some biomarkers to give us an idea of what subsets might benefit. As an example, IRAK4, FLT3 inhibitors look to be really sensitive, not just to the FLT3, which makes sense, but also to, in particular, the splicing mutations, which make up half the MDS patients. So looking at these specific subsets is really important. We're still looking for drugs that can really target these specific subsets outside of IDH1, IDH2, but it certainly has led to a lot of really good science and a lot of really interesting clinical trials.